Ευχαριστώ πολύ για την kind introduction. I'll switch in English language, but I'm happy to answer any questions in Greek if I can. My medical Greek, they're a bit rusty. I'm a pathologist. I don't know if I'm the only pathologist here, but I just want a couple of words from my background.
Είναι και η Βάσο εδώ.
What?
Είναι και η Βάσο εδώ.
Just that, that's right. So switch to industry now.
I'm not practicing.
So in the United States, the pathology is completely subspecialized. Greece is a small country, so pathologists are still general, but so we are completely subspecialized. You're doing a fellowship, you're doing lung pathology, liver pathology, kidney pathology, etc. So I'm a dermatopathologist, skin pathologist, bone and soft tissue pathologist. So in terms of things that are relevant to oncologists, I do every day sarcomas and melanomas. I mean, that's what I do every single day. So, and what I do is I provide diagnosis for you, so you can actually treat the patients with the best available treatment. But providing, I heard some excellent lectures yesterday. I mean, the things that they're doing in Mayo Clinic are just amazing. However, a diagnosis is not being reached only by just doing the molecular. I mean, that's not true. And actually, a lot of mistakes will happen if you just put the tissue and you get all these mutation analysis, etc. They may be very important for predictive purposes for you, which treatment, but for you, you need first to have the accurate diagnosis. And having an accurate diagnosis, it's a whole different story. And it's merging all the available data, starting from the patient, or clinical data, to the H&E, the morphological data, immunohistochemical data, molecular data, and then putting all that together and try to give an accurate diagnosis. So when I have a case, I have a sarcoma or a melanoma, things like that, I don't just see the slide. I actually see the clinical notes. I see the radiology, I see what the surgeon found, what the oncologist think, and then I'm going to see the morphology, then I'm seeing the protein expression, then I see the molecular, and then I put all this together and make an accurate diagnosis. So I'm not going to give you a very hardcore what pathology studies we do here in Dartmouth and collaborating with other institutions in the United States and around the world. I think that's kind of too much. But I'm going to give you what is kind of hot topic in pathology that is relevant to you, and then a couple of cool cases that we had during the last few years that are actually relevant to you. So first of all, starting with sarcomas, and I'm going to talk a little bit about something that is actually kind of a hot topic the last couple of years. And it's a hot topic in pathology more than 2 years because there's a lot of new data coming out that actually may change how you practice. So I want to talk about this first, a little bit of background of biology, this so-called SWI-SNF complex, the sweet sucrose non-fermentable chromatin remodeling complex. And that is kind of important. It's kind of important to you because we see at the last slide that we have new drugs that are actually relevant to these kind of tumors. So what is SWI-SNF? It's a multi-subunit system. We don't understand it very well, but it's very, very important in human neoplasia. And basically, it's a large group of genes that are mapping to different chromosomes. And how that works is kind of involved in chromatin remodeling process, which is very important because has an effect on transcription regulation. And that's which genes are going to be expressed, which genes are not going to be expressed. And the loss of these different components of the SWI-SNF complex is actually a very central molecular event in human neoplasia. And that's how tumors, they initiate. Let me just put that laser point. Tumors, they initiate or they de-differentiated to a histogenetically diverse neoplasms. And it's a very highly coordinated complex that is ATPase dependent manner. So there are a lot of different subunits in this complex. It's actually, and we don't understand all of them, but for some of these subunits, we actually use them diagnostically, and you use it actually therapeutically. SMARC B1, it's the first one. quite a few years now was described, now relatively recently, SMARCA4, SMARCA2. So basically, SWI-SNF, it's a key epigenetic modulator, which its enrichments at promoters and enhancers of active genes determines which genes are going to be expressed and which genes are not going to be expressed. And you see here has almost 15 subunits. Collectively, these complexes act as a tumor suppressor. That's why when you have loss of one or more than proteins, then kind of initiates neoplasia, although some of them actually may have a gain on function, oncogenic mechanism, and it is very, very frequent. More than 20% of human neoplasia has inactivating mutation, and that is almost at the same level you see on P53 mutations. And the changes that you see in this complex, they're not mutually exclusive with other passenger or driver mutations, right? So you can have a driving mutation, you have a BRAF or whatever, and then you can have changes in this complex, which actually explain this heterogeneity. So the first tumors I'm going to talk about is the SMARCB1 deficient neoplasm, and the SMARCB1 is one of the 15 subunits of this complex that maps to chromosome 22, and it's actually one of the most important subunits of the SWI-SNF complex that's responsible for the functional integrity. And what happens is when you have biallelic inactivation through different molecular mechanisms, either deleterious genetic events or epigenetic errors, then you have loss of the protein expression. But a lot of work has been done the last few years, and the final phenotype can look different in different neoplasm. And all these kind of sarcomas, they belong to this kind of broad category of SMARCB1 deficient neoplasm. Very important, epithelioid sarcoma, malignant rhabdoid tumor, epithelioid MPNST. You have in different lineages, carcinomas, we know have I&I loss. And they belong to different patterns, chordoma, myepithelial carcinoma, a lot of different things that if you do sarcoma oncology, you're very familiar with. So the prototypical, the rhabdoid pattern that you see in this I&I, it's the pediatric atypical teratoid rhabdoid tumor. The rare tumor, we've seen quite a few cases, and the equivalent of that outside the CNS is the non-central renal and extrarenal malignant rhabdoid tumor. So this is the prototype of the SMARCB1 deficient neoplasm, and that happens in very young children, less than 3 years old, and it can be unifocal or multifocal and has a very poor prognosis. We've seen cases. It's a kind of fascinating tumor, and the protein expression, the immunohistochemistry is not very helpful except one stain I'm going to show you because it has a variable immunophenotype. And 1/3 of these kids that have this tumor, and it's kind of important, they actually have germline mutations. And distinguishing, if you have a kid with a germline mutation that has a rhabdoid tumor, distinguishing separate primary tumors versus oligometastatic disease is almost impossible. It's kind of arbitrary. So this is a prototype, and you can see here, I'm a pathologist, so I have to show you a couple of pictures. You have a variety of morphology. The final phenotype can look very different. So this is a prototype. This is what we call rhabdoid morphology. You see here that as the nucleus is actually eccentrically located, and you have this dense eosinophilic cytoplasm, this kind of a rhabdoid morphology, but it can look a little bit different here. As you see, this look more like a very high-grade carcinoma, or it can look like a round cell sarcoma. So you can see, even in a non-trained eye, you can see how different these cells look. All this actually is rhabdoid tumor. But what happened is because the I&I is mutated, right? You have a I&I loss. If you actually do the stain, this is the I&I stain, you see that there's loss of the protein expression. You see here brown, that is retained because these are not neoplastic cells, but actually the tumor shows loss of I&I, and that's kind of a very helpful stain to actually support the diagnosis of malignant rhabdoid tumor, which we don't have a lot of drugs, unfortunately, and it's a very, very aggressive tumor. And one other tumor that can be very difficult to differentiate is in children from malignant rhabdoid tumor is the epithelioid sarcoma. The epithelioid sarcoma is another fascinating tumor that is SMARCB1 deficient and has two different types. The classic type you've seen in your career if you do sarcoma oncology is the distal type. It's predominantly in young adults on acral sites. It looks like nothing clinically. I mean, it looks like nothing, a small nodule, and it may actually look like nothing even under the microscope. It's a big fear for the pathologist not to miss this tumor because it's very aggressive. And the proximal type, which is more central, it's kind of a deep pelvic perineal soft tissue, and this tumor has actually a significant overlap with the pediatric malignant rhabdoid tumor. And this you need to put all together. You need to put the clinical stories where, if it's not an infant and it's a young adult on the deep pelvic, then it's probably a proximal type epithelial sarcoma rather than a rhabdoid tumor. And clinically, they look like bumps. And one thing that they do very commonly is to be ulcerated. If you have a bump that is ulcerated in a young individual on the acral sides, you need to biopsy this because actually it may actually be an epithelioid sarcoma. Sometimes it looks like an infectious process. It has a sporotrichoid appearance, kind of mimicking an infection, a lymphangitis kind of thing. But actually, this is a very aggressive. If you don't act fast, it may have a very fatal outcome. And the interesting thing is, it may actually be very misleading under the microscope as well. This here, to the non-sarcoma pathologist, it looks like nothing. This looks like fibrosis. You may get some non-diagnostic, you see a report that there's no diagnosis, but this is actually a fibrosis-like epithelioid sarcoma. And this is an epithelial sarcoma as well, but if I show that to a dermatopathologist who doesn't do sarcoma pathology, they may call that granuloma annulare, which is a benign histiocytic proliferation, but this is a fatal disease. So it's actually very, very misleading, and it is a source of medical legal implication in our field. With lots of high stakes because these are young individuals. But if you actually see more closely the cells, they look more atypical than just benign histiocytes. And of course, if you do stains, they will stain like an epithelial sarcoma, which I'm not going to go into it. But what I'm going to say is this again. This is a tumor that shows INI loss. INI, SMARCB1, is part of the SWI SNF complex, and because it's mutated, the protein expression is lost, and that actually helps supporting the diagnosis of epithelioid sarcoma. But epithelioid sarcoma, especially the proximal type, can have different morphologies. You see here 4 pictures that look very, very different. This looks like a high-grade anaplastic carcinoma. This one looks like a solitary fibrous tumor. This one looks like epithelioid hemangioendothelioma. This one looks like a pancreatic cancer. They're all proximal type epithelioid sarcomas. So it can be very, very difficult, but it's very crucial to make that diagnosis. Another tumor that we have seen a rare tumor, is the so-called epithelioid malignant peripheral nerve sheath tumor. And it can be seen superficially, so dermatologists may actually see that. And of course, surgeons, because it can be deep and visceral, and it's called epithelioid malignant peripheral nerve sheath tumor. And show you a couple of pictures. It looks very uniform. Histologically, it has this kind of multilobulated appearance with this kind of more epithelioid cells, but they obviously, to the trained eye, they look malignant. And if you go high par, they have atypical mitotic figures and very prominent nucleoli. So these are malignant cells. So what is the most common misdiagnosis of epithelioid MPNST, which about 2/3 of the cases can be seen superficially? The most common misdiagnosis is melanoma. Why? Because melanomas are diffusely S100 protein positive, and so epithelioid MPNSTs. And melanomas, it's the big mimicker, it's the clinical equivalent of syphilis. Syphilis can look like anything clinically. Melanoma can look like anything histologically. So melanomas does not necessarily have more specific melanocytic markers. So the most common misdiagnosis is melanoma, but INI1, again, part of the SWI-SNF, if you do the stain, you see loss, where in melanoma there is never loss of INI expression. INI mutations have been described in melanomas, but they have not been described to have loss of the protein expression. So that's a very helpful stain to differentiate it between melanoma and MPNST. And if you think this is all hardcore paths that are not relevant to you, you'll be mistaken. This is a case I had as a fellow. This was from the back of a 35-year-old female who had gone to a very, 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 very prominent institution in the United States and had been diagnosed as stage 4 metastatic melanoma. And this patient then moved to Indiana, where I was doing part of my training. And because in the United States, the serious big hospitals, every patient who has an outside diagnosis, it needs to be reviewed by the pathology department in this institution. You don't take the outside diagnosis and you start treating. It's forbidden, you can't do that. So everything has another review as a part of a QA process. So this patient came to our hospital. So the slides were requested and they were sent to our hospital to review them. And most of the times, you agree. It's 95% of the time they say, okay, it's straightforward, it's melanoma, it's sarcoma, etc. But this one, we happen to disagree. And this is the case. And I'll tell you as a sarcoma and melanoma pathologist, this looks odd for melanoma. This kind of multilobulation and most importantly, this kind of very uniform. You see every cell look the same. Melanomas of that size and in the metastatic side, they don't look like that. So I knew, because I had trained I had trained as sarcoma pathologist as well. So I knew that this is probably an epithelioid MPNST. And of course we did the INI and you see that there's loss. The brown that you see here, there are inflammatory cells that tells you that the stain works. So this was not a stage 4 metastatic melanoma. It was a primary epithelioid MPNST who has different prognosis, still is very aggressive, a different prognosis, different treatment. It changed your management completely. So that's to show you that all this is actually very relevant to your practice as well. And then it becomes even more interesting. This is a very nice paper that they want to see the genomic landscape of clear cell carcinomas or renal cell carcinomas in the kidney. And they found that mutations in this gene, loss of function of this gene, PBRM1, they were responding very well to immunotherapy. And PBRM1 is one subunit of the SWI-SNF complex. So theoretically, you could have studies that they actually study the mutations in the SWI-SNF complex, and if there is mutation, they may actually be responsive to immunotherapy. This is speculative because the studies have done in carcinomas. But what is not speculative is the story with tazemetostat, which got FDA approval last year. And this was the study in Lancet, phase 1 and phase 2 trial. And what happened is tazemetostat, which is an EZH2 inhibitor, it actually may work in neoplasms that have SWI-SNF deficiencies. So they had, in the phase 2 trial, they had responses about 15% and 67 patients, which actually in more than half of the patients, the responses lasted more than 6 months. And what happened is when you have a functional antagonism between SWI-SNF and the so-called PRC2, polycomb complex. And when you have deficiency of the INI1, like epithelioid sarcoma, epithelioid MPNST, etc., you have loss of inhibition of the EZH2, and that drives the neoplasia. So when you have INI, a neoplasm with INI loss, which is has neoplasia driven by EZH2 inhibitor, then when you EZH2, when you give an inhibitor, that may work work against this disease, and that's what the trials show. And tazemetostat had first approval in 2020 for patients both 16 years old and locally advanced or metastatic epithelioid sarcoma, based on a lot of work that was done in SWI, SNF deficient sarcomas. So they're not theoretical anymore. I mean, there is a drug, but of course the right diagnosis has to be given first, and that is actually relevant to your practice. And I've seen a few epithelioid sarcomas from Greece that they sent me from consults. So it's something that you actually, it's rare, but they're here. The other kind of hot topic, I mean, is not like, it's relatively new, but it's kind of important, is the NTRK fusions story, because there is a targeted therapy. And the NTRK, we know we have NTRK1, NTRK2, and NTRK3 genes. And the fusions, they are implicated in various neoplasia. It's relatively common in a subtype of melanoma that we're going to talk. You can see in various sarcomas, infantile fibrosarcomas, and of course other tumors, and they are targetable, and the patients respond in a kind of morphologic agnostic manner. Doesn't really matter how they look, but they actually they may be responsive. But I heard about the lectures yesterday. This amazing molecular, but that's not real life. I mean, we don't NGS everything every day, and we don't have huge panels. I mean, we're not there yet. So the question, and NTRK fusions are in a very small percentage of patients. Of course, depends on the tumor. 1-2%. There's a lot of money to start sequencing every single thing. So when the question arises, when shall I sequence? Where shall I go the next level? And how can I screen these patients that they have this underlying fusion? So people have come with different algorithms. So you have a high frequency, and it really matters how the tumor looks, right? Especially in sarcomas, you can actually predict sometimes if it's going to be an NTRK fused. And you may have a high frequency. Tumors with high frequency, people recommend to go to FISH. If it's positive, you treat. If you have a tumor has intermediate frequency of NTRK fusions, people recommend to go to FISH. If it's negative, you go to RNA fused NGS. Tumors with low frequency, you go directly to RNA fused NGS, etc. And is that relevant? Actually, it is very relevant, and that is a fascinating case that I had a few years ago. This patient had been diagnosed with fibrosarcomatous DFSP, dermatofibrosarcoma protuberans, which is the most common sarcoma in the skin, in 2012. And that's how the tumor was looking like. You have this tumor, this is epidermis here, so this is skin, this is your fat, and this is a tumor here that kind of infiltrates into the fat, and it looks obviously malignant with a lot of mitosis figures, but then it kind of infiltrating the fat in a honeycomb fashion, and it was CD34 positive. So historically, it had been diagnosed as fibrosarcomatous DFSP, which is pretty reasonable diagnosis. The patient had positive margins, but she did not come back for re-excision. And after a year, in 2013, she developed local recurrence. We got the local recurrence. Here's the scar from the primary excision, and then got a local recurrence. That was one year after, and looked like sarcoma, and it was diagnosed as recurrent fibrosarcomatous DFSP. 2013. 2016, I got a metastasis in the inguinal region, and that's how it looked. It has this kind of myxoid spindle cells, and I'll tell you from my experience, say that looks morphologically, it looks kind of weird for fibrosarcomatous DFSP. I've seen hundreds. And so I wanted to prove it, because molecular that hadn't been done at that time, it was like 10 years ago. So I tried to prove that this is a DFSP, which now is very important because, as you know, you use imatinib for metastatic DFSP. And I couldn't prove it. DFSP has a different translocation PDGFB col6A1. And then I have to do NGS because something is fishy here. And we found EML4 NTRK3. And at that time, actually, was the first NTRK fused sarcoma in the skin in a metastatic setting. So that changed your management completely, because we know now that you have targeted treatment for NTRK fused sarcomas and carcinomas, etc., with the first drug being approved, larotrectinib, and then was shown be quite high efficacy in adults and children. And we've done quite some progress since then. So larotrectinib, entrectinib, sotrectinib, all these kind of different drugs that they target tumors who have NTRK fusions, and they actually work in a morphology agnostic manner. And that particular setting, it was very important because you know that for DFSP, either metastatic or locally aggressive, your treatment is imatinib. So that actually changed completely how this patient was managed, and it was kind of important. So that was about it, a couple of things about some new things in sarcomas and how this affect morphology and affect your practice. And I'm gonna switch gears to melanomas. And as you know, melanomas, they've been categorized, classified in 4 different big categories. You have the BRAF mutated melanomas, you have the RAS mutated melanomas, NF1, and then you have the triple wild type. And that a lot of research is being done with the triple wild type melanomas because they actually may find other targeted therapies in this subcategory of melanomas. So how do we get a melanocytic tumor? So what normally happens, you have your melanocytes at the basement membrane, and then they get an extracellular growth factor for some reason, and hits the receptor tyrosine kinase, which can be NTRK, RET, etc. And that gives a signal. Again, gives a signal that actually activates different pathways. You can activate the RAS, RAF, MEK pathway, activate the PI3K, ACT-mTOR pathway, and that kind of leads to proliferation, differentiation, etc. So this is an early event. It's necessary, but it's not the only event that will give you melanoma. This will give you a tumor. You give you a clonal process. For example, a nevus. A nevus is a tumor, which is BRAF mutated or NRAS mutated. But to get melanoma, you need to have additional hits. It's a progressive, a model of progression. What happens is when you get a nevus, right, you get a BRAF mutation and you get a nevus, then what happens is we'll have so many nevus in our body, not all of them will become melanomas, most of them will not become melanomas. What happens is the cells that go to a senescent because there are breaks. You have the P16, you have P53 breaks, so they keep the tumor aboard, so you don't have that don't progress further. But if you start getting additional mutations in other genes because of UV radiation, etc., then you actually have progression to intermediate melanocytic lesions and at the end melanoma. And that's kind of important because we, as you know, we have targeted treatment, and so much have been done the last 10 years in melanoma treatment. And this is, if you get activation of the tyrosine kinase of the kid, then you have activation of both pathways. If you get mutation in GNAQ, GNA11, that is very common in uveal melanomas, and it's common in a subtype of other melanomas. You get activation of the BRAF, MEK, and ERK pathway. So you have different drugs now that you can hit different parts of the pathway. You have BRAF inhibitors, MEK inhibitors, tyrosine kinase inhibitors. Like you can see, they hit the different areas of the pathway that leads to the development of melanoma. And the important oncogenes in melanogenesis is BRAF, NRAS, HRAS, GNAQ, GNA11. These are important driver mutations that it can actually lead to melanocytic proliferations. But these are early events. You need additional hits to get melanoma. So we actually know a lot about the molecular pathogenesis of all these different melanocytic proliferations. You know, see nevi, the majority of them, they have BRAF mutations. a small component that have NRAS mutation, blue nevi, uveal melanomas that have GNAQ, GNA11 mutations, the UV-related cutaneous melanoma, they have BRAF, HRAS, etc., and they have schizoid neoplasm. So you can see that a melanoma, it is not one disease. It's actually a lot of different diseases with a lot of different molecular pathogenesis. And for example, uveal melanoma, the great majority has GNAQ, GNA11. They don't have a significant tumor mutation burden, where if you see the cutaneous melanomas, they have a significant tumor mutation burden. That's why they respond so well to immunotherapy. And most commonly, they have BRAF, where you go to mucosal melanoma, they have a very low tumor mutation burden, and the BRAF actually is not that common, etc. So the paradigm has shifted, and the old people, the old dermatologists say, well, it's universal melanoma. It's not true anymore. There is a genetic evolution. That's why we see a lot of lesions that are somewhere in between morphologically. You know that it's not a nevus. You know it's not a slam dunk melanoma. They're somewhere in between. And this is the evolutionary model. You can start for benign, invasive melanoma metastasis, melanoma in situ, and there's intermediate lesion, and you see that the point mutations are different. The volume of point mutations, copy number aberrations, the mutational signature, driver genes, it is an epigenetic model, and we see that in a tumor that we struggle a lot, the Spitz tumors. So this is benign, this is your epidermis, and these are your melanocytes here at the basal membrane. And what happens if you get a mutation on BRAF, HRAS, or you get a kinase fusion, you get a nevus, a Spitz nevus. You probably have that when you're a kid. But a Spitz nevus is a benign neoplasm. Then you have tumor suppressor mechanisms that they keep this neoplasm at bay, and it doesn't transform further. But if you get additional mutations, like you get P16 deletion, P53 inactivation, you get something that looks a little bit more ugly, but it's not quite there as melanoma. And if you get additional genetic aberrations like third promoter mutation, etc., you get something that is unequivocally melanoma. And we see that if we do comparative genomic hybridization, and we use that a lot. We have a huge database for diagnostic purposes. You see nevus here. These are your different chromosomes. Nevus is quiet. It's just a line, which means there are no combinable gains or losses, as our colleagues from Mayo Clinic showed yesterday. But in a typical Spitz tumor, low risk, you start seeing something different. Then if you go to high risk, you see more gains or losses. And then when you go to melanoma, you see a lot of gains and losses. And we have translated that, SNP array is not widely available. Nobody does that in Greece, as far as I know. We have translated that to FISH. We got the data from the SNP array, and fluorescent cytohybridization, it's a cheaper technology. It is available in Greece. The melanoma FISH is more complicated, but theoretically could be done here. They got this huge data, and they say, okay, what is the most common aberrations that you see in melanoma? And they develop specific targets for these genes that you can run a fluorescent in situ hybridization. And people seen that tumors who have homozygous 9p deletions or BRAF mutation, P16 expression, etc., they actually did a comparative analysis to see if they can make a diagnosis. And this was a fascinating case from a 10-year-old. Now, diagnosing melanoma in a kid, you have to have tremendous experience, one. And second, your threshold is very, very high, because melanomas in kids, they behave actually pretty well. Very, very few of them are fatal. So this was actually a fatal melanoma in a 10-year-old. You can see here the cells that they look pretty malignant and atypical. And the FISH actually show increased 6p, increased 11q, and homozygous loss of 9p, which is a signature for melanoma. So it can be really helpful in making the accurate diagnosis, because if you just rely on H&E, especially in kids, you're going to get a lot of kids' melanomas that actually are not quite true. But the Spitz melanomas is a different story. The Spitz melanomas have different molecular aberrations. They have fusions. they have HRAS mutation and BAP1, and it's a mixed bag. You may have seen your reports when you treat patients with speech-rate melanomas, and I can tell you that probably 1/3 to 2/3 of them they're not true speech-rate melanomas, because you really need molecular analysis to be certain. And the true speech melanomas, they have kinase fusions. So this is a speech melanoma with ALK fusions that actually may respond to crizotinib. You have a treatment here. And you can see here that the true speech melanomas, they have mutations in HRAS, or they have fusions in kinase fusions, but they don't have any mutations on BRAF, NRAS, etc., where on the contrary, the non-speech, they have mutations that they affect the MAPK pathway, like NRAS, NF1, KIT, etc. And one that actually it's a relatively hot topic is the melanomas with activating RAF1 fusions. So this is, as an oncologist here in Greece, you're going to have a melanoma, you're going to do a BRAF, it's going to be negative, you're going to give immunotherapy in advanced melanoma. But if you actually do more advanced genomic deep sequencing, you may actually have other options in some of these melanomas, because that's a lot of research is happening in the triple negative wild type melanomas. So 2.1% of the triple negative wild type melanomas, they have RAF1 fusions that actually may respond to MEK inhibitors. And this was actually a case that responded to MEK inhibitors and it didn't work very well. Immunotherapy didn't work very well in this particular case. And you see this, it doesn't have any BRAF, NRAS, NF1 mutations, none of that stuff, but it has a RAS1 fusion, which so it can be very relevant to you, how you're going to treat this patient. And actually we had a case with melanoma, acral melanoma with metastasis, that it was BRAF negative, it was negative for NRAS, etc., but actually it was RAF1 fused with another partner in that particular case. So the oncologist, the melanoma oncologist, they had options apart from immunotherapy. They have options that actually more other drugs may actually work on this patient. So it's not theoretical, it's not exotic, it's something that you see that in real life when you actually start doing deep sequencing in these tumors. And another subtype of melanoma in the triple wild type category is melanomas with in-frame deletion of MAP2K1. And that is another small percentage of the triple negative melanomas that actually may, experimental models have shown that actually these tumors, these are actually oncogenic driver event. They may actually respond to targeted therapy. So a lot of things are happening in melanoma, and you can see here that this melanoma didn't have any BRAF, NRAS, or NF1 mutation. So that's actually very relevant, and if you don't do deep NGS sequencing, you're going to miss that. And as you know, a lot of things have happened in the melanoma treatment, diagnosis and treatment. Of course, you know, immunotherapy is all over the place now in melanoma, but sometimes it doesn't work that well. People, you know, get recurrence and stuff. But if you have more comprehensive genomic profile, you may actually have different options as well. And since 2010 is this amazing, the exponential growth of knowledge and treatment possibilities in melanoma patients, and now, you know, all these targeted therapies that you use in your everyday practice. Well, I hope it wasn't too hardcore path, but I want to mention that I have established an international health fund with my university, so I do see a lot of consultations from all over the world for free. We actually provide the funding. They send me a lot of cases from Greece, either sarcoma or skin. We do everything for free. If we do more molecular that are not available here, or the patient doesn't have money to pay them, we'll do them for free. So if you have any cases that you need further second opinion, or you want to collaborate for research, I'm happy to actually see the case, issue a report, do everything that is needed. So that can be initiated by the patient, the pathologist, or the oncologist, or the surgeon, doesn't really matter. So this is my email, and this is Dartmouth. It's 2 hours north from Boston. It's very nice in the fall and the spring, in the summer, but then it gets really cold with a lot of snow. Well, thanks very much for your attention.
Βασιλική.
Κωνσταντίνα, thank you very much. Ήταν υπέροχη ομιλία σου και συγχαρητήρια και για την πρωτοβουλία, γιατί πραγματικά είναι πολύ σημαντικό να ξέρουμε ότι υπάρχει πρόσβαση σε κάποιον ο οποίος είναι τόσο αφοσιωμένος στη συγκεκριμένη υποειδικότητα. Ανοίγουμε για τις ερωτήσεις. Ξέρω ότι είμαστε αρκετά πίσω, αλλά μπορούμε να έχουμε μία-δύο. Και αν μου επιτρέπετε να ξεκινήσω εγώ, γιατί μίλησες για τα N-track fusions και το Laro, οπότε η ερώτησή μου προς εσένα θα ήταν πόσο ανοιχτό νομίζω ότι θα είναι το πεδίο για καινούργια διαγνωστικά εργαλεία τα οποία βασίζονται σε AI περισσότερο παρά το standard of care FISH ή ανοσιοστοιχημία.
Well, I think AI will come first, not in terms of genomic profiling, but in terms of actually morphological diagnosis. But specifically for N-track fusion, I don't think AI will play that much of a role, because we cannot predict morphologically which ones are N-track fusions or not so far. The sarcomas, there are some hints which ones are N-track fusion, but I can tell you many times that they're not what we expect morphologically. I think you need a huge database, and these are not very common tumors, to actually put all these cases together, and then AI come up with something that we're not able to come up in terms of actually predicting by morphology which kind of going to be N-track fused or not. It may happen, I don't know, but at this stage, we're not very good at telling, well, this is an N-track fusion neoplasm or not, at least in the mesenchymal world. I don't know in the carcinomas. I don't think it's different there.
Thank you.
Do you have any other in the industry? Any other insights there? Are they capable of saying what is?
So I'll switch in English. The problem is that, as you mentioned, that the prevalence of these tumors is pretty low and high heterogeneity. So the morphology is pretty diverse. But I'm just asking because the idea, as you mentioned, would be to skip the absolute need for NGS, or at least identify the patients that would need the NGS, so as to stratify a little bit the expenses and give opportunities for targeted therapies to patients that would never have.
I think what's going to happen is, because NGS, it's getting so cheap every year, is going to happen is before the slide reaches the pathologist's desk, they're going to have their genomic profiling already in the system. So because it's going to be so, I mean, we're not there yet, we take a couple of weeks to get the results, but it's soon, and it's going to take 5 years, 7, 8, it's going to be so cheap and fast that I'm going to open my screen, I'm not going to have my microscope anymore, I'm going to see the slides in the screen, and I'm going to have the genomic profile of the tumor before I actually see the slide. I mean, that's what's going to happen, but it'll take some time.
Thank you.
You might make many pathologists unhappy this way.
Actually, yeah, I mean, actually, I think it's going to be, what people don't realize is like the more we study this, we realize the promiscuity of these molecular events. You see that the same molecular events in neoplasms that they look completely different. So actually, for me, it's going to be, I welcome this because I can make the diagnosis faster, but I have to combine that with the morphology, because you see exactly the same fusion in 5, 6 different neoplasms that they look completely different. So actually, you need everything starts from the morphology and comes back morphology. And I trained with molecular pathology. I don't practice 30 years, and I was very enthusiastic about molecular pathology, and I still am. But the more I practice, I realized that the cheap, old H&E morphology is like so important to make accurate diagnosis. So it's a combination. It's a combination of things.
Ωραία, Βάσο. Νομίζω ότι ήταν μια πάρα πολύ χρήσιμη και όμορφη παρουσίαση και τα σχόλιά σου well taken. Θα μου δώσει το δικαίωμα να παρουσιάσω την επόμενη ομιλήτρια.
Μήπως θα μπορούμε να κάνουμε μια ερώτηση πριν. Μια ερώτηση από το ακροατήριο. Thank you. Ευχαριστώ. I'm very excited because I actually follow you a little bit. We're on LinkedIn and stuff, so I follow your lovely work. I work on melanoma immunology and immunotherapy, and I'm very aware that the immune response is already there in some of the tumors in melanoma, but not others. What I don't really have a feel for, and probably you know a lot about it, is how are these different immune environments associated with different mutations in those mutational profiles in your experience? Because I know you guys count as well, you know, the T-cell infiltration, the lymphoid, right?
Yeah, but we're not at this stage, I mean, clinical practice, I'm not subtyping which one is CD4, which one is CD8, how many macrophages.
But just generally, I mean, do you see something different in terms of the, you know, hot, you know, or cold tumors in any of these particular?
Yeah, we report, you know, what is the tumor infiltrating lymphocytes, if it's brisk, they're not brisk, etc. But in terms of how this difference of immunological response, what I see on the slide, how that translates to when you give the immunotherapy, I don't have a very solid answer on that.
I'm just wondering because the mutational changes
Correct.
also are seen by an immune, you know.
Correct, but I don't think I can't correlate or can't predict, or what I see on the slide in terms of the infiltrating lymphocyte response, what is the mutational landscape of this particular melanoma. So I really need to see the genomic data.
Okay, no problem. Thank you.